This brings us to the next talk of Sami Lachkar. Sami Lachkar is a very experienced interventional pulmonologist in Rouen, in France. Good evening, Sami.
Good evening, Kalispera.
Kalispera. Bonsoir.
Bonsoir. It's a pleasure to be there with you, Iraklis. Thank you for your invitation. Grigoris, hello. Philippe, hello. Hello, Kelvin. So, yes, it's a pleasure to be there and to share my experience about how I perform the diagnosis of peripheral lung nodule and when. You see my slide? It's okay?
Everything is okay.
Grigoris, could you confirm?
Everything is okay. You can go on.
Everything is okay. So perfect. So, I say Philippus, when you find peripheral lung nodules, in many cases, depending on the probability of lung cancer, in many cases you can refer it to the surgeon. In many cases, in few cases you can observe it, but in most cases you need to perform the diagnosis. What is peripheral lung nodules? Peripheral lung nodule for us bronchoscopists cannot be reachable with a conventional bronchoscope, which means a 5mm scope. Indeed, the study showed that conventional white light bronchoscopy with a 5mm scope should not be routinely recommended for patients with peripheral lung nodule because it leads to very low diagnostic yield. That's why you can use the percutaneous CT guided method, but it's lead to a lot of pneumothorax, it's cumbersome, it's a long procedure. You can, of course, send it to the surgeon, but you can perform the diagnosis by yourself with bronchoscopy. That's why we decide to know what about the strategy of the diagnosis. First, you need to have a symphylis CT scan in order to see what? In order to see the bronchus sign. The bronchus sign is essential for the bronchoscopist in order to going inside the lesion. After you're finding it, you need to choose the right vehicle. You need to, and after that, follow a route. And after that, you need to know if you are arrived inside the lesion. So which vehicle? Obviously, my favorite scope is a 4mm scope because it's a thin scope with a working channel which is the same than the other one, that's the standard scope. You can choose a 3mm scope, but the working channel is a little bit thin. Why is a 4mm scope? In this example, you have these small nodules here, 8mm. If you choose a standard scope, a 5mm scope, you will stuck on B3. And now, if you choose a 1mm less, you will win 1 division, 2 division, and 3 division. 1mm is enough to win a lot of division after. The advantage is the maneuverability, the extended range bronchial selectivity, the better tolerance, of course, for patients under local anesthesia, and the adequate sample. But it's fragile, and it's not a problem of the operating side if you choose a 4mm scope. After that, you need to choose the route. To choose the route, you have a virtual bronchoscopy. But watch out, when we're talking about virtual bronchoscopy, you can, you can have the virtual bronchoscopy without navigation. That means with only a planner. The bronchoscopists need to memorize the pass with a simple software. For example, this software, you put your CT scan inside, it beats you a 3D, you put a mark on your nodules, and it creates for you a pass. And then you have to memorize the pass and go with your scope. In the literature, the literature shows that it you win sometimes, and of course you increase the diagnostic yield of the bronchoscopy. After that, you can use the virtual bronchoscopy with navigation. That means with a synchronization between the bronchoscopy and which is the real bronchoscopy and the virtual bronchoscopy. It can be the Archimedes platform, it can be the Vero platform or the Longpoint platform, but it's more expensive and a little bit more cumbersome. And this is the same, you can use electromagnetic navigation, but also it's more expensive, a little bit more cumbersome. After choosing the route, you have to know if you arrived inside the lesion. For that, you can use fluoroscopy, but the limit is that you cannot visualize the lesion less than 2 centimeters. It's only in 2 dimensions. Of course, it's irradiated and it's a little bit cumbersome in a operating room. But you can see the stability of the tools. You can see if the lesion, if the sample is open, if the biopsy is open, and it's important for the needle sampling. For the cone beam CT, the advantage is comparing to the standard fluoroscopy, the 3-dimensional visualization and the relationship between the target lesion and the biopsy tool, so real-time guidance during the biopsy passes, and the fluoroscopy visualization of the small lesions and moreover with the gland opacities I cannot see with a fluoroscopy. But it's costing, you need to setting, it's irradiated, and it's a little bit logistical issue. We use the radial IBUS, which is a small probe, about 1.4 millimeters inside the guide sheath that you can put inside a thin bronchoscope. You can add the guide sheath, the kit, including guide sheath, biopsy forceps, brush, and add the needle per review flex. It's very easy. You follow the path, you select the right broach, and then you push your right probes inside the guide sheath. You find the lesion, and then you let the guide sheath in place and perform the sample. You don't need to learn about ultrasound. It's white when you are in the normal lung, and it's black when you are inside the nodules. What about the diagnostic yield? In the literature, it's about 70% and few complications. The influencing factor are obviously the bronchus sign and a little bit less the size of the lesion. But it could be also the position of the probe. If the probe is inside the nodules and you have a concentric signal, you will increase your diagnostic yield. But if the probe is outside the lesion with a tangential, the diagnostic will be a little bit decreased. In her experience in Rouen, in Normandy, in France, we started in 2006 with electromagnetic navigation. And after a few procedures, we stopped because it was too expensive, too long, too cumbersome, and it needs to use a 6mm scope. So we're going in maybe the main bronchus. You need to use another general anesthesia, and then we move to simply routine methods since 2006 by using VB planner in order to plan the road, 4mm scope in order to reach the smallest bronchus leading to the lesion, radial IBUS in order to confirm that we arrive to the lesion, and guide sheaths to be confident to staying in place during the samples, but we never use fluoroscopy or cone beam. I showed you an example. You see here a small nodule, but you see here there is a bronchus sign. You have a bronchus sign. There is no doubt that you can go inside. So you're following the path. So you are on B8, then right, then left. So you memorize B8, right, and left. You are stuck here. So you will see I take a little bit of saline, and then the nurse give me the probe plus the guide sheath. I push it on the direction, and yes, I'm in with a tangential signal. I let the guide shift in place. The nurse take out the probe and give the brush tool, and then I brush inside the lesion, and then I put it on the slide for smear. I can recontrol. You see the nurse performing smear. I control to go inside the lesion, maybe to have a more concentric signal. Yeah. And then I push my biopsy forceps. You will see the biopsy forceps is open, and then I perform some movement in my hand to crush the lesion and put it in formalin. And then I will control it and perform many samples. And that's it. Perform 4 or 5 samples. We published recently this manuscript about our 10 years experience, first 10 years experience, about more than 2,000 radiolibus with the same routine. VB planner, 4mm endoscope, radiolibus, gaseous, endoscopy. Our diagnostic yield was about 70%, but it increased when the final diagnostics was lung cancer. You see that we select the patient based on the bronchus sign or the vessel sign, and in most of cases it was performed under local anesthesia because it's well tolerated and it's very quick, less than 10 minutes for an exam. And the molecular analysis was possible in 77%, and the PDL1 in more than 80%. That's why in our area it became the first line bronchoscopy with 84% that are referred to our centers without previous standard bronchoscopy. The limits offer it at the price, but it's not very expensive, about 200 euros for one procedure, but this probe is frightening. You cannot see and detect the pure gas ground opacity because you cannot make the difference in ultrasound between the pure gas ground opacities and the normal lung. And of course, if you don't have a toe leading to the lesion, maybe you decrease your diagnostic yield. So what about the nodules without bronchus sign? I say sometimes, try it, it could work. You see, you see this lesion, you don't have bronchus sign. I put a mark inside the lesion. I follow the path. I memorize the path. And then I'm going to try to push in the right direction. So I'm stuck here, and then I will take my probe, wash the probe, and then finally I can have an images. So I'm confident to stay in place, and then I perform my sample. If not, you can use more complicated tools such as bronchoscopic transpirational approach with electromagnetic navigation, with cross-country, or with Archimedes. It works, but it's a little bit complicated to approach it, and it's a little bit longer, I think. In my facilities, I send it to the transthoracic needle aspiration or to the surgeon if I cannot have the results with my simple tools. So, the recipe for me in my daily procedure, it's not only for publication. I use it every day, 30 procedures a week for diagnosis. I can put 1 month fiducial marker and 1 per week a paradigm marking for the surgeon. It's again VB planner, 4mm bronchoscope, radiolibus, gaseous, no fluoroscopy. But maybe the future could be the diagnosis without sampling. That means with a small probe who can say, okay, you are inside a tumor, it's a PA1 plus, it's EGFR plus, or maybe the future could be the same thing without doctors, with robotic procedure, but it's actually, as say Stefano, may be very expensive and maybe limited to the treatment, as Kelvin will show us in a few minutes. So thank you for your attention.
Thank you, Shami, for this very informative and personal talk, because I liked a lot that you gave your personal experience, frankly, without only literature and published data. And to be honest, I was a little bit surprised because you said twice that you use no fluoroscopy. You were very absolute to that. I think that we may had some comments on this approach, because sometimes when the bronchial sign is not clear or the nodule is very high or very in a big distance from where the scope can be located, then probably the fluoroscopy can be of help, of assistance, because you don't find all the time the nodule with the radial probe. I totally agree that radial probe is the one and only instrument that is really necessary, whatever else you use with it, because it's always combined with something else. Even in robotics, they need radial, even electromagnetic needs radial, everything needs radial. So radial is the one instrument to use, but fluoroscopy may also be of assistance in my experience, and I know I would like to also hear some comments from the other experienced bronchoscopists in the room. I don't know if Stefano would like to comment on that.
Hi, Samim.
Hi, Stefano.
Could you see me or just hear me?
I can see you and hear you.
Oh, great. So perfect. So, congratulations for your talk. I like the lecture that report personal experience, and I know that in your center you have a huge experience on this topic. More or less the same procedure that we use, but we don't use the guide sheet, and this can save some money. We use fluoroscopy, and we visualize with fluoroscopy the position of the probe, of the ultrasound probe, and then we go in the same place with the needle. Or what I would like to ask you is, we have a good experience with two points. We had a good experience with the ultra-thin bronchoscope that is 3 millimeters, and that half of the passage both of the radial probe, ultra-thin probe, and also of the needles that can be used. You can approach more close the lesion, and you can bend the tip of the scope that can be useful for the lesions that are not inside the bronchial tree, but that are tangents to the probe. So the second is a comment. Unfortunately, the transbronchial approach to peripheral nodule is completely heterogeneous from center to centers, and there are no randomized studies that really compare the advantage of one technique in comparison to the other one. We see now a lot of paper on robotic bronchoscopy, but the cost of robotic bronchoscopy is probably not affordable for every center, because you have 2,000–3,000 euro of disposable material, and sometimes it's not necessary to have, and we have no randomized study that compare, for instance, electromagnetic navigation with, if you look at the study, there are a lot of technique together. In your study, there is a virtual bronchoscopy plus EBUS, and other study use electromagnetic navigation and radial EBUS. Other study use combined CT, radial EBUS, electromagnetic navigation. I wrote an editorial on respiration together with Alex Rothman that on this topic was titled Dancing in the Dark. The problem is that while we need a lot of patient and randomized study to accept a new drug that should demonstrate that is equal or superior to the previous one, for this kind of instrument, the companies put this instrument on the market just on the basis of 20, 30 cases performed in excellent center. So this is one of the main problem of the guidance system. Everybody say, my system is better than the other, is better than the previous, but we have no very well done randomized study on this topic. What is your opinion?
Many thanks, Stefano. For answer to your first question about the use of the 3mm scope plus radiolabels plus copy, I don't have the experience because first, the fluoroscopy, we got a small room in our facilities and we perform it under local anesthesia. So it's cumbersome to add fluoroscopy in a small room under local anesthesia. That's why we use 4mm scope, guide shift, and because we are confident with the guide shift staying in place, we don't perform fluoroscopy. And that's the first answer. And the others, I completely agree with you. There is no data and comparison about the different systems. Otherwise, there is a new meta-analysis. There is a new update of meta-analysis. It's just from Cheng Emoli, who says that there is no difference actually about all the systems: robotic, electromagnetic navigation, radiolabels plus BP. There is no, as they are all about 70% more or less. So, and because I use this way, because it's simple. I don't want to spend more than 10 minutes inside the branch of the patient. Heracles, you can confirm that you was there. It's very easy, very simple, and I don't want to spend more time inside the patient. That's what we use that. And if not, we pass to another things like CT, percutaneous CT scan, CT biopsy, or surgery.
Okay. Thank you very much, Sami. It was very clear. And that brings us to the next question. If we arrive to the lesion, what will we do with that? If it's operable, apparently the patient will be led to the operation room. But if it's not, could we do otherwise? So we have here the next speaker.
It is a great pleasure to invite, to present my friend Kevin Lowe, who is an